Hello everyone. Hello everyone and welcome to Bridge Clinics. Hello. Welcome everyone. Welcome to this live session. Ask Dr. Tambari anything. It's great to have you on this, day where everybody is out celebrating, but sometimes we need answers to some things, and so it's cool to be able to come in and ask those questions. So this is a special live session where we're going to be answering your questions related to whatever fertility issues you might have. And so we would like you to post your comments in the comment section and we can answer them. And as we go along, share the link with your friends so that they can come in as well and ask questions as needed. Okay, so how many people can see me? I hope you can all hear me. If you can hear me, please post in the comment section that you can hear me. All right, that's great. Good to have you. Okay. All right, so welcome everyone. I see you. All right, so we will start shortly with one or two questions. And I think the first thing we're basically going to talk about is infertility. So we're going to define infertility and we're going to try to understand what exactly is infertility. Because when you see a couple that is not, they don't have a child, they're not getting pregnant, you really want to know what's going on, okay? And occasionally, it actually turns out that the couple is not trying to get pregnant, okay? So if the couple are trying to get pregnant, then we can now say after a period of 12 months, then they might have some issues with infertility. So this couple has to have been having regular unprotected sexual intercourse for at least 12 months, so 3 times a week without protection, and they're not able to get pregnant, then there might be challenges with fertility. So they have to be in the same city, living in the same, meeting frequently. When we've established the fact that this couple is actually not having success, then they want to see their doctor, their fertility experts, and find out what the problem might be. Now we have causes of infertility that are related to the male and causes that are related to the female. So because the woman carries the pregnancy, a lot of people look at her and say, maybe this is why we're not getting pregnant, but that's not the way it works. If there are challenges with infertility, it could also come from the man. All right, so the major things that we typically would look at would be some of the male factors, key of which is the semen parameters, how the sperm looks like and what the qualities are. And then we also look at some female parameters. You want to know what's going on with the ovaries, where the eggs are. You want to know what's going on with the tubes, the fallopian tubes, and you also want to know what's going on with the uterus. But you have to understand that for pregnancy to occur, this is a whole couple. The couple is a whole unit. So the woman herself has to be fit. All right. So everything about the woman has to be okay. Hello, Ngozi. You're welcome. I see you. So we're talking generally about causes of infertility, and for the woman has to be okay physically. So you want to make sure that medical she have blood sugar issues, then her blood sugar has to be properly controlled. Does the woman have any issues with blood pressure? Her blood pressure should be properly controlled. She has to be fit so that she's in a good, physical state to actually carry a pregnancy. Hi Ngozi, if you have any questions, please let us know. We're just answering one or two that we have seen along the way. All right, so invite your friends, send the link to your friends so that we can continue. I'll give you a few minutes to get your thoughts together. Today we are asking and answering any questions related to fertility. So we're here to answer your questions if you have any. So We're going to go on to talk about some of the common things that we have in this our setting. Okay, we're in Africa, we're in Nigeria, and we're proud of that. We're not in UAR, but what are some common things that we find in this setting? Key: fibroids. Fibroids are masses. Okay, we call them tumors in medicine, but not cancerous tumors. Now, these are non-cancerous growths that actually occur on the uterus. Now, when you're looking at the uterus, it has different layers. But one thing we realize is that fibroids are actually commonest in black women. So black women have a lot of fibroids, and so we see a lot of fibroids in people. Some people say, oh, I've taken out my fibroids once and they grow back again. Why did they grow back again? As long as a woman is still within her reproductive age, then she can have fibroids growing and regrowing, okay, because of the effect of her hormones on her uterus. But when she reaches menopause, then new fibroids typically do not grow. So we want to know what's going on with the woman in terms of fibroids. Now, fibroids could occur anywhere in the uterus. The uterus is actually almost similar to an upside down pear, an avocado, almost similar to that. All right, so you have the body of the uterus, and then you have it narrowing down into the cervix. And by the sides of the top of the pear, you actually have the fallopian tubes. So you could have any fibroids from the body of the uterus or down to the cervix. Now, depending on where the fibroid is, it may or may not obstruct the ability to get pregnant. This means that some women will get pregnant with their fibroids, but some women will not get pregnant because they have fibroids. It's really a really thin line for experts to say this is exactly why a woman is not getting pregnant. For some people, you think, oh, with this fibroid, she's definitely not going to get pregnant, but she will get pregnant and she might carry that baby to term. So it's a bit subjective, but we know that when the fibroids are bigger, they make the uterus bigger than a certain size, then getting pregnant also becomes a bit difficult and a bit dangerous to the woman's health, because that fibroid coexisting with that pregnancy may cause some complications in pregnancy. For some women, they have fibroids in the lower part of the uterus, so delivery can even be difficult. So typically, we would assess fibroids on a case-by-case basis, and we might want to decide, do we need to take out these fibroids or can we leave them in? So depending on what we find, we might go either way. Okay, so with fibroids, it's really a thin line. Fibroids can cause other effects. Sometimes, because of the position, they can actually even obstruct the entrance to the fallopian tubes. And when it obstructs the entrance to the fallopian tube, or it's kinking the fallopian tube, then it makes it difficult for the sperm to actually go and access the egg. And so there is some difficulty for that particular sperm and that particular couple, because getting pregnant will actually be tough. So let's take another question. One question is, how will I know if my tubes are blocked? How do I know if my tubes are blocked? You said, okay, the fibroid might be blocking the tube, and some people will say, oh, it feels like when I'm ovulating, the egg is not dropping, so it looks like my tube is blocked. Fortunately or unfortunately, it's actually difficult for you to just say, by sitting in your house that the tubes are blocked. It's actually quite difficult. Now, if you have blocked tubes, the only way to really assess it is by doing investigations, medical investigations. The most common one that we have is something we call a hysterosalpingogram, or an HSG. An HSG is basically a procedure where you pass a dye from the cervix, which is the bottom of the uterus, and you inject that dye so it flows up through the uterus and out through the fallopian tubes. And when that happens, you can see the path of the fluid by taking x-rays. And when you take those x-rays and the radiologist looks at the film, the radiologist can say, okay, these tubes are open or these tubes are blocked. Occasionally, when you do an HSG, it could show that the tubes are blocked. And if those tubes are blocked, sometimes it's because of spasm. So this is what we would call like a false negative. So the tubes may not actually be blocked, but because of that fluid passing through it, it causes the tube to kind of like shiver and close. And when it does that, then you have the fluid not passing through. So you could have spasm showing that the tube is blocked, or you could have actual blocked tubes. Now, if the tubes are blocked it depends. We ask how many tubes are blocked. If one side is blocked, the other one should be able to function. Also note that when a woman has something like an ectopic pregnancy or a tubal pregnancy, that tube is taken out, so that tube is not functioning anymore. So if the fluid is not passing through one tube, the other one should actually be able to accommodate if it is functioning properly. But if both tubes are blocked, then we have a challenge here, because the sperm doesn't have any way to get to the egg. And if the sperm doesn't have any way to get to the egg, then it's difficult to achieve pregnancy. So the couple have to look for another means. And this other means that, can solve the problem is assisted reproduction, ICSI, IVF, IMSI. Now, what happens in that situation is you're actually taking the sperm and the egg and you're helping them to meet in the lab in a medium that is similar to what entails in the human body. And when the egg is fertilized and it has grown a little bit, then you can put that fertilized embryo after 5 days into the uterus, the fertilized egg into the uterus, and hopefully there will be implantation and eventually pregnancy. Okay, so you can't know if the tubes are blocked just by staying at home. We've talked about an HSG. Another procedure that we can also do to know what's going on with the tubes is something we call a lap and dye. A lap and dye is still, you're injecting a dye into the tubes, but you're doing a laparoscopy, which is basically looking into the abdomen. You go through the belly button with a small scope like a camera. So when you go in with that camera and you inject the dye, you can actually see whether the dye is pouring from the tube. So it's like if you fix a hose to a tap and you open the tap. The fluid flows out from the other end, you can see it. So with the lap and dye, you can see your fluid pouring out, and then you are sure that your tubes are open or your tubes are not open. Now, we talked about the sperm meeting the egg. How do you know if the man actually has sperm? Some people say, my husband ejaculates, and when we finish meeting, everything pours out. And this is really distressful to a lot of people. Why is it pouring out? If it pours out, it's finished. So then it means that we don't have anything to get us pregnant. Now, when we look at semen, all right, which is what is produced on ejaculation, we have what the parameters that we need to define. So there are qualities of the semen that we are looking for. All right, the same way a woman will cook a pot of. So now when you look at the man's semen sample, we look at what is the quantity. If the quantity is too little, then it might mean that, yes, even though there is sperm, there might not be enough to do the job they need to do, because this sperm moving is actually a race. They are racing to get to that egg in time before, the egg is not viable anymore. It's like if you are running to catch a bus. If that bus leaves, you have missed it. You might have to wait hours. In this case, the sperm might have to wait another month before it gets to another egg. So what is the quality of the sperm, of the semen? So we talked about volume. Ideally, you want to have about 1.5 ml of a semen sample. That is average. Okay, for most people, it will be about 1.5, maybe 2 ml, and this is actually very small if you measure it. So we don't need a whole large quantity. Talk about volume, you want to know what are the numbers of sperm cells inside. So when you look at this sample under a microscope in the IVF lab or in the fertility lab, what are they actually sperm cells? So if there are sperm cells, we are happy. Now the question is, are these sperm cells enough to actually get to the egg, right? So you want to have at least 15 million sperm cells in 1 ml of your semen sample. And having those 50 million gives us a good assurance, at least to an extent, that those sperm might be able to get to the egg. If the volume is too low, or the number rather, is too low, then you're worried that the numbers of the sperm cells might not be enough to fertilize that egg. And some sperm cells, it's like you're running a race. When you're running, see people running a marathon, so people will fall along the way, be panting, they're tired, and that same thing happens with the sperm. So some will fall back along the way, some will die along the way, and the rest will see if they can get to the egg. So you really want to have a good number of sperm cells. Then we look at the sperm cell structure. The sperm has a head, a neck, and a tail. You want to know, is the tail straight, is the tail bent, is the head straight, is the head bent? So now we're looking at what we call morphology of the sperm. If the sperm is abnormal, then it is actually difficult for the sperm to do the work. So swimming might be difficult if the tail is bent. When it gets to the egg, if the head is not okay or the head is abnormally shaped, then penetrating that egg might also be difficult. So we are looking at the shape and structure of the sperm cell. Then we also want to know what is the motility. For the ones that are swimming, you have different kinds of sperm cells. You have the ones that are just jogging on the spot, but they are not swimming forward. You have the ones that are strolling, so they are going slowly. We call them slow progressive, and we have the ones that are sprinting, so we call them rapid progressive sperm cells. Now we also have the sperm cells that are dead, so they are not moving at all. Now imagine if you have a semen sample and you have high levels of the semen, of the sperm in the semen sample. You want to know, is it, is this, the sperm are all dead? Are the sperm moving at all? Are they not moving at all? We want to know that. Okay, so those are some of the things that we can look at. All right, so we're going to look at some of more questions that we have here. Chichi says, is it possible that after embryo transfer you can still test negative to pregnancy? Unfortunately, yes, it is possible, because when we have embryo transferred, you are transferring a viable embryo. All right, but this embryo has to get into the uterus. It has to implant, and when it implants, it now has to grow into a fetus. So if the uterus or the situations in that time are not ready for implantation, then it's actually difficult to get your embryos or your pregnancy to test positive. One thing we understand is that even in the bedroom, even when we're trying naturally, pregnancy rates are not 100%. An average woman who is in her 20s has a 25% chance of getting a positive pregnancy every month. So the same thing happens with IVF. In IVF, you have slightly higher chances. The worldwide average success rate is actually about 35%. So that tells you that not every IVF procedure will succeed, even when you have good quality embryos and everything looks fantastic. So I hope that you don't give up. One negative test does not mean that we can never get pregnant. You can do another embryo transfer and even get pregnant. Okay, so the average woman will need between 3 to 5 IVF cycles to get pregnant once, which is almost a bit similar to the trend we have in the bedroom. So don't give up, keep doing your embryo transfer. Another question says, can hyprolactin be cured? This will depend on the cause of the hyprolactin. All right, so prolactin is a hormone or a chemical that the body produces, and this prolactin is produced by a gland in the brain which is called the pituitary gland. And when the pituitary gland secretes this prolactin, sometimes there's excessive stimulation that makes the prolactin come off. So some medication will actually make your prolactin be high. If we identify that medication, we can stop them and maybe the prolactin might come back to normal. But if we find that the prolactin levels are caused by, the hyprolactin levels are caused by maybe a small tumor on that gland called a microadenoma, then that tumor might need to be removed for the woman to get her prolactin levels normal. So we can investigate the cause, and if we find the cause, then we deal with it. The prolactin levels may get back to normal. Okay, so that's one of the things that we have. Now, she says she's been treating prolactin for about 17 years. So you need to actually have these prolactin be investigated further, because one of the common causes of prolonged high prolactin level is actually what I talked about, the macroadenoma. So we do a CT scan of the brain, all right, and when we investigate, we may be able to find out whether that is what the cause is or not. All right. So somebody says, what can cause seizure of period for 8 months now? This is actually very distressful to a lot of women, because when your period stops, it feels like things are not okay. And the thing, you can't even go out freely. I'm wondering, like, what's going on? Is it going to come and meet me on the road? So you need to see your fertility doctor, because you need to find out a number of things. Are your periods regular on a normal day? Okay, do you normally have periods coming every month? Do you have any issues with hormonal issues? What is your age? All right, now a woman starts her period at a time we call menarche, during puberty. That indicates the start of the period, and when the periods end finally is called menopause. Leading up to menopause, when the periods are going to stop, we have what we call perimenopause. In the perimenopause, you see the periods can come for some time, go for some time, will flow slowly, come back. So it gets irregular. And then sometimes you have the period going for a long time. So when the period stops for up to a year, in a woman who is older, typically towards from like 40 and above, we can say that this woman has reached menopause. But we also have premature menopause in younger women. So you can see a woman in her 30s or her late 20s whose periods have actually stopped. And if that happens, it means that the woman has a condition we call premature ovarian failure. And if there is premature ovarian failure, then the woman will need fertility assistance to get pregnant. So some women also have complications after childbirth. Okay, so issues with the inner part of the uterus with scarring and all that could make the periods not to come. Of course, after delivery, we know that a lot of women will have no periods for a while. So this would mean that you need to get your doctor to take a history and eventually, find out what your own particular cause of no periods is. Now, all right, Julia asked, Doctor, please, I've not been feeling my ovulation signs for months now. Does that mean I'm not ovulating? Julia, I'm happy to say that it does not mean you're not ovulating. Sometimes I ask myself this question as well, because I realize that a lot of people ask about signs of ovulation, and I check myself, like, I don't have these ovulation signs per se, so maybe me too, I'm not ovulating. But I find that, sometimes the signs may be misleading. Some people don't have any signs, but some people have signs. So the question is, what is your sign? For some women, the month they don't have signs, you could also use an ovulation predictor kit. That might help. Or you could go as far as even tracking your ovulation, looking at the follicles and seeing whether, the follicle that has matured, which is the mature kind of egg on the ovary, but the follicle is not the egg. The follicle is the house of the egg. The egg develops inside it. So when you do a scan and we say we are doing follicular tracking, it's not the egg we're seeing a follicle. Now, one thing we realize is that when you look at a follicle and it's maturing, it's a really good sign. But sometimes the mature follicle might release an egg that is not so fantastic. So that is also one of the reasons why a woman will not get pregnant every month. So you might actually have an egg released, but you might not have, that egg doing what it's supposed to do. For some other people, you might have a follicle that does not even rupture at all. So the egg doesn't even have a chance to get out. So seeing no signs does not mean that you're not ovulating. It could just mean that your body is changing, and so you might need to observe that or speak to your fertility specialist and find out what's going on. We talked about blocked tubes a little bit earlier, Lillian. So we said if your tubes are blocked, it's difficult to know. You actually have to do a test. So the common tests that we would do are either an HSG, which is a hysterosalpingogram, okay? In other climes, you also have a hysterosalpingo, they use saline instead of dye. And you could also do a lap and dye, which is a laparoscopy and dye test, where you actually see the fluid or the dye coming out of the tube. So that's the only way to really know if your tubes are blocked. So Dara says, my period lasts 4 to 5 days, but since 2 months now, it lasts 2 to 3 days. I need your advice. Now, the period actually would vary. For most people, they don't have a constant, period. So I would also ask similar questions like I did to one of the earlier people. What is your age? Okay, what things could have led up to this? Some people have shorter periods when maybe that cycle they don't ovulate. Some people have shorter periods when they are ill, so there are different things that could cause a woman's period to be shorter. But having shorter periods does not necessarily mean that there is a problem. That's one thing that we need to remove our minds from. One thing we find is that once we're trying to get pregnant, a lot of the time we think a bit in the negative. I'm not trying to be offensive, sorry, but we need to also not blame ourselves too much, because when we think about these things too much, sometimes it just wears us down. So if your period is lasting 2 to 3 days, then I would need you to speak to your doctor. Your doctor will ask you a lot of questions. So it's called a history taking. What are some things that may have led to your own particular period shortening to 2 to 3 days? And is there anything that can be done to correct it? Some people have sexually transmitted infections. One common sexually transmitted infection, which is chlamydia, actually causes a lot of scar tissue. So you know how when somebody has like a burn and the skin heals, it doesn't heal back normally, yeah? It heals with a lot of scarring. So when you have an infection, it irritates the inner part of your uterus, and you could also have scarring. Sometimes when you have scarring, the tissue inside there does not regenerate as well, and it could make the quantity and the quality of the bleed actually less. Some people also have scarring after surgical procedures, after evacuations. So we want to know what exactly is unique to you and why is your own period, shorter. All right. So if I could ask, please, is it possible to have pregnancy results a few days after the period? I would say yes. So I'm assuming you did a pregnancy test a few days after the period. I would say yes. So the body is very interesting. For some women, even after they get pregnant, they'll tell you, I see periods. If you ask the women, their periods might not be like a regular period. So maybe somebody who sees her periods for 4 days, uses 3 pads a day, might be seeing a bleed and is only having maybe 1 pad a day. The bleed is not too much, So the periods for somebody who is pregnant are not typically like the regular period. Also, when a woman is pregnant in the early stages, a few women actually conceive twins and one of them goes out. So she might be seeing that bleed and saying, oh, this is a period. Okay, then later finds out she's pregnant. So yes, it's possible to do a pregnancy test and find out that you're pregnant a few days after your period. Okay, so Miss Queen says, can 60% dead sperm, 30% actively motile impregnate a woman? So when I was talking about the sperm earlier, I talked about, this is motility we are talking about, that's how well they swim. I talked about motility, but I also talked about morphology. What is the shape of the sperm? The sperm has to also look normal. What are the numbers of the sperm? If you have 60% dead sperm and the sperm is maybe like 5 million, that will not be a good, quality sperm. But if you have sperm that is up to say 20 million, then this might be, okay, because this motility is borderline. We need a minimum of 32% progressive motile sperm. Progressive means that they are not standing in one place, they are moving forward, okay? So if you have 32% of, progressive sperm, motile, then that would actually be good. So 30% actively motile, I would assume that you also have a few percent sluggishly motile. So if the numbers are good, if the volume is good, then yes, you should be able to impregnate a woman. The other thing we need to find out, we need to know, is that when you're talking about impregnating a woman, most times we're talking about the natural methods, right? But even for those with low counts, you can get a woman pregnant, but you might have to do some assisted reproductive techniques. Okay, now somebody says, my breast is usually painful after ovulation and stops immediately I see my period. Checked my hormones and they are balanced. What could be the cause? Queen, I'm very sorry about that. A lot of women, a lot more women that would actually say have this tender breast before their period. Okay, there's something we call premenstrual syndrome. And some women, one of the common things most people will see is breast tenderness. Some people also have mood swings, they get upset, they get, really irritable. Some people feel bloated, some people feel, have diarrhea and all that. And all this stops breast, after your ovulation, just before your period, and then when you see your period, it stops. So the second phase of your menstrual cycle after your ovulation is called the luteal phase. So the body is kind of already trying to get itself in the mood. Let me see if I will get pregnant, and then when that doesn't happen and everything resets for the next cycle, then the symptoms go away. This is also why it's important to do your breast examinations after your period. So when you see your period, that's a good time to do your monthly breast exam, just to check, make sure there are no lumps, because when you do it and it's painful, you might not examine properly. That's if it's just before your period, but afterwards, it's easier for us to actually examine the breast. Okay, so those are most of the questions that we have. We'll just take one or two more. Someone says, I've been battling with staph infection. What is the reason I have not gotten pregnant? Staphylococcus has become quite popular in our society these days. Now, Staphylococcus is actually a bacterium, all right, in a family. So the common one we talk about is Staphylococcus aureus. And Staphylococcus aureus is a bacteria which we call a normal flora. So it's the same way when you go to the forest, you expect to see grass and you expect to see trees. When you check on the human body, the skin especially, you expect to see staph. If there is no staphylococcus, then there might even be a challenge. So when we see staphylococcus in a lot of our, some of our samples, we ask, was there some contamination? All right, so you want to know, when you collected the sample, how was it collected? Because a lot of the time staphylococcus is a contaminant. So there are other things in that test you will be looking for to see whether this staph is actually a problem or not. Most people who have good immune system, that means you're not immunosuppressed, you're not on any medication, maybe after a transplant, you're not on any cancer medication, you don't have HIV, if your immune system is okay, most times you will not have repeat staphylococcus infections. We need to find out what in particular is actually causing your repeat infections. That's if you have symptoms. But if you don't have any symptoms and every month you just go and do a test and check, that might not be so great, because you are looking for a problem when there is no problem. So there might actually be no staphylococcus. All right. So staphylococcus typically will not cause infections of the genital tract that might cause difficulty with getting pregnant, but that's why everybody has to be investigated on a case-by-case basis. Now, Lydia asks that we should explain PGT. PGT is a procedure called pre-implantation genetic testing. That is pre-implantation, G for genetic and T for testing. We have different types of PGT depending on what we are looking for. PGT is a procedure that is usually done as an adjunct to an IVF cycle. Why do you have to do an IVF cycle to do PGT? Because you are doing an analysis of the embryo, which is the fertilized egg. So after the sperm has met the egg, what is going to implant in the uterus is actually the embryo. So you are doing, if you need to analyze that embryo, then ideally you should have it readily available for that analysis. So in IVF, you take the egg from the woman, you take the sperm from the man, you put them together, like I said, in conditions that are suitable, and then while it is in the incubator, this embryo is growing and progressing and dividing. Now, on the 5th day, once you have the embryo at what we call blastocyst stage, you're going to take a small sample of cells, which you call a biopsy. So it's like you're pinching it a little bit. Now, when you take that biopsy, the actual embryo is kept frozen in storage, and that sample is taken to the genetic lab where it is analyzed. Now we are looking at what we call the chromosomes, which are things that make up the actual cell of the body. So when you look at these tiny chromosomes, you have an idea of what is going on. There are certain conditions that are linked to these genetic disorders. So we want to know, does this embryo have any of those disorders? So one of the common things that we see in our society is sickle cell. All right. Now you can have a woman who is AS who is very in love with a man who is AS. It does not mean they cannot marry, but they understand the risk of having children who are sickle cell positive. And if they have those, they also understand the headache that is associated with taking care of sickle cell children. So they want to find out, how do we have a child that is free from sickle cell? You do PGT. So once you have this analysis done, they can tell you that this child or this embryo, who is not a child yet, it's just an embryo. So this embryo is sickle cell. This one is not, it's clear. This one is a potential. So you get those results, and then instead of having to get pregnant and know that, oh, this one is sickle cell and aborting, before the child even goes in, then chromosomes, you also get to know the sex of your baby or of your embryo. So you know that this embryo I'm putting in is free from sickle cell and it's also male, and this other one is female. So that's what PGT will basically do for you. So PGT gives you more information about your embryos, and that actually helps to make an informed decision as to what you are going to carry. Okay, now so we've done quite a while. I don't know if we have any more questions. Okay, it's been a really great and fun session. So I think if you have any more inquiries, you could divert your inquiries to enquiries@thebridgeclinic.com. Okay, it's been really great having you all on this call. Okay, so I'm going to go with Marcus's Glory's comments or her question. Let me answer you before I run away. She says, please, I'm always having irregular periods. Sometimes it will cease for 3 months without pregnancy. I'm so sorry about this, ma'am. You know, we addressed the question like this just a little earlier on. You need to see your doctor who will ask you questions, all right? And these questions would really guide us to what is going on with you. It's difficult for polycystic ovarian syndrome or PCOS. And when you have PCOS, because of these irregular periods, we also have cycles where it's difficult to predict ovulation, and of course it's not difficult to time pregnancy. So you need to speak to your doctor, let your doctor ask questions, and let's see, because this will depend on things like age, it will depend on whether you had any procedures done, whether you're on any medication, whether you have any sickness, you know. So there are a lot of things that would actually tell us why you're not seeing your periods regularly. And once we find out, you know, what's going on, then we can actually, you know, help, and by God's grace you can have what you want. So it's been really great having you all in this live session. Like I said, if you have any further questions, please contact enquiries@thebridgeclinic.com, and we are here to help you and to answer your questions. You can even drop direct messages on the page and we will have answers to your questions. Thank you so much. I remain Dr. Tambari Femi Oluwole, and it was great having you in this session. Bye.